marked. They're not really marked. So would anybody like to start the game off and just ask for a category and an amount? Stuff for 500. All right. Differentiate DI versus SIADH. Anybody got an answer? If you guys want to talk, you can talk, or you can raise your hand, or you can just put some stuff down. Yeah, Mrs. Witt's favorite stuff. Anybody remember the difference between DI?
You know that DI starts with a D, so what does that mean? Deficient, right? So when you're deficient, think of your bucket of sand, pour the water out. What do you have? Yep, hypernatremic, hypokalemic, you're urinating constantly, your specific gravity is low. Okay, good. And what medication that someone may receive if they have DI? What medication? Are we ever going to restrict fluids on someone with DI? That's right, desmopressin. Would they ever receive furosemide? No. Would they ever have their fluids restricted? No. Good. And SIADH, what's SIADH caused from? Unusual. What causes SIADH a lot of times? What causes SIADH? Yep. But what other medical diagnosis? Yep, it's usually some type of lung cancer like small O. That's right. Good. Okay.
Who wants to choose next category? Hodgepodge for 500. Okay. Celestone. Ooh. What's Celestone? Remember it? Anybody? It's a stone, so what does that give you? Tells you a little bit of something. What kind of a drug is it? Another name would be betamethasone. It is a steroid, good. Betamethasone, Celestone, dexamethasone. They're all used for a specific thing. Remember, this is hodgepodge, but it can go all the way back to Unit 1, Unit 2. Lung maturity, good. So it's a corticosteroid. So there's your steroid given to pregnant women to speed the fetal lung maturity. So you remember that way back when we were talking about the preterm babies? Whenever somebody was pregnant, we wanted to get their baby delivered, but we wanted to check to make sure that the baby's lungs are mature. It helped speed up that surfactant production so the baby can be delivered. All right, next. Remember these? Let's do this one because it's already, one of these is already done. Did we do stuff? Let's do learned stuff, just because it's blacked out. Daily double. Labs and clinical manifestations of DIC. So this is going to be a lot of things. So what kinds of things do you see with DIC? What kinds of?
Excessive bleeding where you shouldn't be.
Okay, good. What else?
Clotting where you shouldn't be clotting.
Clotting where you shouldn't be clotting and not clotting where you should be.
Right.
So, all right. Remember the prolonged PT and the PTT, the decreased fibrinogen and platelets, and you have that increased FDPs. What is FDPs? Does anybody remember that? FDP? Remember the fibrin degradation products? So your fibrin gets all broken up and makes like little tiny clots. And then you also have the fibrin's not working the way it's supposed to, so it's not making big clots like it's supposed to. So you bleed. So you have petechiae. Remember what petechiae is? The little spotches on your skin. Oozing. So there's your bleeding everywhere. You ooze from all your sites. Your mucous membranes ooze. Your old IV sites will ooze. Hypotension, of course, because if you're bleeding out, your blood pressure goes down, your heart rate goes up. Good. All right, that was a daily double, so you got 1,000 points for that one. All right, we're going to do fun stuff just because it's already marked as well. Fun stuff for 100. All right, primary cause of COPD in the United States. What is it?
Smoking.
Excellent. Good. Can you hear this? No? Aw, I cheered you. Everybody cheered. Okay. All right. Okay, so now somebody pick a new category. Good stuff for 100. Okay. Ooh, it's a picture question. What is this? What is it showing? Early D cells, Chris says. Everybody agree? Early D cells? Does it look like it's mirroring? So what causes early D cells? Head compression, good. So remember, the head compression causes early decelerations. So think about veal chop. Let's see, we can go back to that one real quick. So this one, remember, see how it goes up and slowly they meet together. The nadir and the acme are lined up. The decrement of the contraction and the returns to baseline up here. What's this little thing here? Does anybody remember what that's called? This little bump right there. Acceleration. Good. All right, so early decels cause head compression. What do we do about early decelerations? Nothing. Good, because they're benign. You do not have to fix early decelerations. What might you want to do? You don't have to fix them, but what would you don't have to do any interventions, but what might you want to do if you start seeing those on your screen? So reposition is that would be an intervention for if we needed to fix things. But yeah, we need to do a badge exam because what's a head compression telling us? Baby's head's being squished, so it's probably right there. Yeah, baby coming. Good. All right. So pick a next one. Anybody? Fun stuff for 200. A known contraindication for methylorgonavine.
Isn't that high blood pressure?
It is high blood pressure. Good. Hypertension. What would be the other drug that we talk about? So what do we give methylorgonavine for? What's its purpose? Anybody remember what we give methylorgonavine for? Postpartum hemorrhage, correct. Remember, you never give it to somebody who's pregnant. It's only for postpartum hemorrhaging. So there's the 4 drugs that we talked about with postpartum hemorrhage. Does anybody remember what the 4 drugs are that we talked about? In what order? First one's easy. Oxytocin. Good. Start with oxytocin. Then, if they don't have hypertension, we'll have the methylorgonavine. And then what's the next one? Anybody remember the next one? Carboprost. Good. Remember what the contraindication for carboprost was? Asthma. Very good. All right, and what's the last one that we can give? Postpartum hemorrhage. Misoprostol. Good. And that's the one that you've had before. That's the GI, can work on the GI bleed kinds of stuff. It's also for, it's a prostol, so it's a prostaglandin, and you can give it to ripen the cervix before they deliver, but you can also give it for postpartum hemorrhage in big bits. Very good. All right, next question. Anybody? Interesting stuff for 100. Macrosomia, hypoglycemia, anomalies, temperature instability. What do these things have in common? What are they referring to? So diabetes while pregnant. So who is affected? What is the, I mean, it has to do with some diabetes. Yeah, this is the baby. So this is the fetal or the newborn complications of gestational diabetes. So what is macrosomia? Macro, big baby, those big floppy babies. And what was the other questions on there? I forgot. Hypoglycemia. So remember why are the babies hypoglycemic when they're born? Or maybe not when they're born, but why did they become hypoglycemic so quickly? Anybody remember? Blood sugar getting cut off from the cord. Good. So they're used to getting all that glucose. They've built up their own insulin. And then when the glucose stops, their insulin takes over and drops their blood sugar down so quickly. Very good. So kind of coming back to you, this is a long time ago. We talked about this stuff. All right, next question. Who wants to pick? Stuff for 200. Stuff. Diagnostic test used to determine thyroid activity. What do they use to determine the thyroid? What's the lab or the diagnostic?
T4 and TSH.
Yeah.
And what's the correlation? Matthew, well, I think that was Matthew. What's the correlation whenever you're hypothyroid? What will you anticipate seeing? Hypo. I'm putting on the spot, but anybody.
T3 and T4 will be low, and then TSH is high, and then vice versa.
You are correct. Ding, ding, ding.
Good job. Here, we can make it cheer, but.
Yeah.
It really is had this cheer button and a boo button. It's fun when you were sitting in class. Okay.
Let's do
Next one.
hodgepodge for 100.
Hodgepodge for 100. What is variability? Ooh. Oh, that's the question, though, I think. Maybe. I don't know. Let's see if it... That's weird. Okay. The bump. Good. Most important indicator of fetal well-being. Variation in the heart rate. Good. That is correct. There's no go-to answer over here. So this is the answer to that question. I think it said, what is the most important indicator of fetal well-being? I think was the question it's supposed to be. Sorry. Don't know what happened there. Okay. Next. Anybody? All right, stuff for 100. Given to babies prophylactically and also as an antidote to warfarin. Vitamin K. Good job. Anybody want Miss Witt want to say anything about vitamin K? You good? Why do we give it to babies?
Because they don't have enough clotting factors, right?
Right. So because they don't have the ability to synthesize their own yet. Why don't they have the ability to synthesize their own? Oh, somebody said it. For their little sterile guts.
Oh, yeah.
Yeah. Because they have sterile guts, they can't synthesize their own vitamin K, and vitamin K is to help with clotting. So, good. All right, next. Learned stuff for 100. This results in pulmonary congestion. Anybody? Left-sided heart failure. Very good. Cheer. Miss Wood, anything?
Left-sided heart failure. What are signs and symptoms? Pulmonary congestion. What else? Wet lungs. That's right. And what are the signs for? What's another word for right-sided heart failure? What's another term? I think I heard it. Cor pulmonale.
Too.
Don't get cor pulmonale mixed up with coarctation of the aorta. So cor pulmonale, and you know the symptoms of. We talked about that till I'm blue. We know what signs and symptoms for cor pulmonale is. Yes. Way to go! Ding, ding, ding. Good job.
Okay, next.
Let's do interesting stuff. 200.
Glycemic control over the past 90 to 120 days.
Hemoglobin A1C.
Good. And then another word for that is the glycosylated hemoglobin. I know I pronounce it glycosylated. Miss Witt, you say it differently than I do. I don't know what you call it.
Glycosylated. I don't know. Whatever. A1C.
Yeah.
You know
The
what
hemoglobin A1C.
Right. And you know what normal is? You know what normal is for a non-diabetic versus a diabetic? That's correct. And you know how I always say the proof is in the pudding. That is the proof. If they say they're eating right and they're exercising, this will tell the truth.
Kind of like your final exam. Your final exam is your glycosylated hemoglobin,
Yeah.
but all the exams up till then were the daily blood sugars.
That's correct.
There you go. Okay, next. Interesting stuff for 500. Clinical characteristics of DKA. What is DKA first, and then what are the clinical characteristics? Diabetic ketoacidosis, good.
Kussmaul's breathing, fruity breath.
Good. What else? What's their pH? Their blood.
They're acidotic.
Right. So which way
Low.
does it go? Low pH.
Low pH.
That's right. That's right. So what is their glucose? It's high. DKA. What causes people to have DKA? What causes for anyone to have hyperglycemia? So remember that question on the exam, and a lot of people they put missing a meal or skipping a meal. Would that ever cause hyperglycemia to skip a meal? No. So read carefully. Read very carefully.
Isn't it uncontrolled diabetes?
It is, but you're hyperglycemic, yes. And it could be from stress or infection or Thanksgiving or something, that would be increased.
What about who gets DKA more frequently? Like you get DKA, which type? Type 1, good. And type 1 what's the difference between type 1 and type 2?
Yes, why do they have ketonuria? Why do they have the K in the DKA? They have no insulin, so what happens? What are they using for fuel? Their own protein, right? They're breaking down, they're catabolizing their own. And what do you know? What are some of the first signs and symptoms if you suspect someone has DKA? We used to call that juvenile or children's. Mothers would bring their children in and they say, gosh, he's eating and drinking like crazy, but what is he doing? What's one of the number one things that tells us, yes, losing weight. Yes, because their cells are starving. What is if you don't remember anything, what is the only insulin, the purpose of insulin? What does it do? How many times have I said that too?
The door into the cell.
Yes, it does not metabolize. It does not break anything down. All it is transport to bring that into the cell. And people still miss that. They say it breaks down. It does not. It's just transport. You know that. You know that. And with type 2, why do they not have the ketonuria? Why do they not have the ketones? Because why? They still have a little bit of insulin, that's right. So what condition do they go into? If type 1s are DKA, type 2s are HHNS. That's right. Good. Okay. So they're not acidotic because they have a little bit. They don't smell fruity or acetone or Juicy fruit gum, I always say. They don't smell like that because they have a little bit. That's right. Good. Good job.
Next question. Anybody? Be brave. Good stuff for 200. All right. Respiratory distress, murmur, poor feeding, cyanosis, edema, infections, activity intolerance. What do these all have in common?
Heart failure.
As far as who?
For babies.
Yeah. So common cardiac, whenever infants have cardiac problems, they have the poor feeding and the all the stuff that was on that slide. I don't remember what it said. Okay, next question. Whenever babies are sick, what's the first thing they show us usually? How do they show us they're sick? First thing we notice. You think it's poor feeding? What do they do? Right. So if a baby starts to get sick, maybe they're just cold. Maybe they're getting a little bit of an infection. Maybe they got a little cardiac problem. Maybe they got a little bit of something. They show us with respiratory first. So they start off with respiratory. They get tachypnic. They start getting tachypnic, and then you start going, hey, there's something going on here. Then you start checking them out a little bit further, and then you start finding things like, oh, they got a little murmur, or they're having some retractions, or they're sick, or their labs are off, or something. So then they have the signs of respiratory distress. What are all the signs of respiratory distress in a newborn? What are the things we look for? Respiratory distress in a newborn. Think of that, Silberman Anderson. What do you see? Yeah, retractions. Remember they had the different levels of retractions. Nasal flaring. It could be cyanotic. Retractions. They have the opposite ways of, so they have nasal flaring and they have that seesaw respirations, grunting. Good. Those are all signs of respiratory distress in a newborn. So remember that baby with that grunting and those retractions, the video that was on your course stuff. All right, next question. Hodgepodge for 200. What's the contents of the umbilical cord?
Ava.
Good. I can't remember. I think you guys might have all gotten that one right on that first test. Remember I told you that nobody's ever gotten in all these years? I think you guys did. I think you guys got Ava correct on that first test question. So good job. Don't forget the Wharton's jelly. What's the purpose of that? That's what you told us. Okay. Insulation. Yeah, that's the insulation. It's protect those just like your electrical cords, your insulated electrical cords. Protect those little tiny vessels. All right. Next question. We've got like a thing going on here. Fun stuff for 500. An accumulation of air in the pleural space causing loss of negative intrapleural pressure. What is that? Pneumothorax. Good. You guys typed very quickly and spelled it right mostly, so good. So pneumothorax, think about those. Anything, Miss Witt, you want to talk about pneumothorax? Anything?
Yes. What do you see with a pneumothorax? What causes a pneumothorax?
Traumas.
Yep, trauma. That's right. Deviated. Okay, you see a deviated trachea. What else might you see with a pneumothorax? Unequal rise in chest. Has anyone seen that before? That's pretty scary. That's right.
Babies can get a pneumothorax just from being born.
Yes.
You know that? That pressure change.
From that do you have a picture of that, Dr. Colburn, with the pneumothorax, with the baby?
Yeah, in my office.
Yeah.
I'm not there.
Yeah. That might be a little problem. Yeah. But yes, and you know what a pneumothorax is, and you know what it looks like, how do they treat a pneumothorax? What's the treatment for
Chest tube.
pneumothorax?
I think Matthew said chest tube.
Mhm.
Yep, chest tube, and we'll talk about chest tubes in fourth semester. Mr. Royalhausen does an excellent, you'll have a simulation on chest tubes. It's really,
Did he do that in third?
did he do it in third? I know he does it in fourth.
No.
Okay, I thought he showed you
in
guys the-
third and fourth mixed up, but I know we
Can't
did
they
it
happen
fourth.
from?
Can they also
What's
happen from a, yes, they can also happen from thoracic, that's correct.
Ooh, yeah.
Yeah, it's scary. Yeah.
That would be bad.
Yeah. If they slip or, I mean, maybe the anatomical, the patient too, yeah. But good thinking, Hannah, but ugh, you're correct.
How did they position when they do a thoracentesis?
Tripod position.
Yeah, sit them up and lean them forward, tripod position. Who else does tripod position that we know of?
Orthopnea. CPDers.
COPDers, good.
Why do COPDers, why do they prefer the orthopnea or the tripod position? What does that do to them?
Because they have like wet lungs, so it's easier for them to breathe. Right?
That's right. That's right. What are some other breathing assessments you'll find with a COPDer? That's right. So their diaphragm can expand more, their lungs can expand. And you know, patients who can't lay flat, pursed lip breathing. What else? That's right, Elizabeth.
Low
What else?
L2
What do you see when their shoulders move up and down? Use of accessory muscles. And what is accessory muscles? What's the purpose? What's that do? What else are they doing besides the accessory muscles? What are they doing with their lips? Pursed lip breathing. And why? What's the whole reasoning behind all that?
To try to get rid of CO2.
That's right. Good. And what's that cough that we talked about?
Huff coughing.
That's right. That's correct. And how do they do? How would you perform the huff cough?
You use a pillow to splint their chest or abdomen.
And then and take a big breath in, and then what are you doing when you're huffing? On expiration, yeah. What's the purpose of a huff cough? Kind of
To
gross.
try to get rid of secretions.
That's right. That's right. And when you see the word non-productive, what does that mean?
It's no secretions are coming up.
That's right. Good. Okay. You are correct. So,
Next question. Good stuff for 500. Immediate action upon discovering a boggy uterus. Massage. Good. And don't forget to, what do you need to do when you massage? What should you do?
Hold pressure.
Hold pressure where? Yeah. So you need to make sure that you do suprapubic pressure so that you don't push the uterus out. Yeah, suprapubic pressure. So you're pushing on the top of it to massage it, but you're also you're anchoring that bottom part so you don't push the uterus out. What's it called? What's a boggy uterus? What's that word? That medical word for boggy uterus? What's it caused? What's the reason kind of behind boggy uterus? Remember the word atony? So they have uterine atony, not clamping down like it's supposed to. Whenever it does clamp down, what's that big long word? Starts with an I. What do we want the uterus to do? When it clamps down, goes down about a finger breadth every day. Normally. Involution, good. So you want uterine involution. When it doesn't clamp down, what's the problem? Why does it matter if it doesn't clamp down?
You can hemorrhage.
Yeah, postpartum hemorrhage. So they can just keep bleeding and bleeding because nothing's shutting the bleeding off. The uterus uses those muscles to shut down the bleeding. So if the muscles are not contracted, it's just going to keep bleeding. All right. Next question. Hodgepodge for 200. Encourage foot care for a diabetic patient. What is that? Why would we do something like that?
They have poor perfusion and poor wound healing.
They do have poor perfusion. They have poor wound healing because of diabetes. What kind of health promotion activity would this be?
Therapeutic?
Good. Somebody said tertiary. So, this is secondary. This should be a tertiary prevention. It's not a secondary prevention. That's wrong. It's a tertiary prevention.
Feet or tertiary? Yes.
Feet or tertiary.
Yeah.
So because for tertiary they already have diabetes, and you're trying to prevent them from their feet falling off, basically. So that's a tertiary prevention. So sorry, didn't pay attention to that one. What would be an example of a secondary prevention?
Screening.
Yeah, screening. So, you have a specific group of people that you're screening for something. So you're screening a bunch of women for breast cancer or lung, skin screening. So screenings, when you're looking for a specific thing, but they don't have it yet, or you don't know that they have it yet, you're screening them for things because they have a potentially higher risk for something. That's a secondary. What's a primary prevention?
Vaccines.
Yeah, vaccinations and education. Those are the two main primary preventions that you think about. Education, you educate lots and lots of people to stop smoking, stop doing, or don't start smoking and don't do drugs and all that kind of stuff. That's primary prevention. Okay. Next. Anybody? Fun stuff for 300. Okay. Swelling of the fetal head that does not cross the suture line. Does not cross. What is that? Cephalohematoma. Good. So cephalohematoma is the one that does not cross. What's the other one? You could use the short version. Caput. Good. So the caput's the one that crosses. You wear your cap all the way across your head, but a cephalohematoma is in the periosteum of the bone, so it can't cross the suture line because the bone stops. So cephalohematoma. All right, next question. Good stuff for 300. Spironolactone. What's that?
It's a potassium sparing diuretic.
Case sparing one. Good. So potassium sparing diuretic. And what does that mean when you say potassium sparing? When we watch their labs? What did you say? I missed it.
It keeps potassium.
All right.
Level.
So don't give it if your potassium's above 5. That's a good rule of thumb. And potassium needs to be monitored. Good. Okay. Next.
Interesting stuff, 300.
You don't sound very interested. Symptoms of hypoglycemia. So symptoms of hypoglycemia. So what do they look like? Sweating, pale, sweaty, nervous, anxious, tired, hungry. Hunger, lethargy, confusion, tremors, diaphoresis, pallor. Good. Remember they're low and they're they're sweaty and pale, and if they're high, they're what? Yep, high, hot, and dry. So good. So they're red and high and dry and good. All right. Remember that. So sweaty is low. Next. Learned stuff for 200. Look, 2 people picked the same thing. Given to babies prophylactically and didn't we already do this one? Yeah, vitamin K. We already talked about this one. Okay. Next. Stuff for 300. You guys are scary. So, all right. Treatment for Addison's crisis.
You better get
What,
this
first?
right.
Goes down.
Can they ever be weaned off of cortisone if you have Addison's? No, never, never, never. What do you worry about with Addison's crisis? You might go into what? Into a coma, and death will occur. That's right. So what should they always carry with them? What should they have in their glove compartment or in their purse?
Cortisone pen
That's right.
or cortisol pen.
That's right. And what else do we know about a person with Addison's? Emergency card or bracelet. That's right. And remember, sometimes these people can have like exacerbations, kind of like with asthma or sickle cell, where they can feel like a crisis, like if they're in nursing school, with stress, they can feel it sometimes coming on. So sometimes they have to give themselves a little extra boost of cortisol. But they can never, ever, ever be weaned off of that. Ever.
Don't have any of their own. Why do they need an emergency bracelet or card? Why do you think that is? Yeah, because people will think they're drunk or there's something else wrong with them. They need to know to give them the cortisone right away. They don't want to take them and stick them in a drunk tank like the old days.
Yes, they'll act like they're under the influence. So yes, the same like with a diabetic. They should have some type of let them know.
Stuff for 400. Look at you guys. You're weird. Stuff for 400. The 4 ways that babies lose heat. Convection. That's one. Conduction, evaporation, and radiation. Good. All right, so let's talk about what are they? Conduction is they lose heat by what? Conduction with a D. How are they losing weight or heat? Touch. It's touching something cold surface. All right. What about radiation? How are they losing heat that way? Radiation. So radiation is when they're not touching but close to. So that's radiation's the cold wall. I'm sitting next to a cold wall, I'm not touching the wall, but the wall is pulling my heat away from me to the wall. So radiation. The air one is what? What's the air movement? That's convection. Like your convection ovens have hot air moving around, but cold air will take the heat away from the baby. And what was the last one? Evaporation. How are they losing heat that way?
That's from sweating.
Yes, it's sweating or just the insensible air moisture lost from their lungs.
Mm-hmm. Okay.
Just from breathing. They're wet when they're born, so they can lose the heat that way. So anything with water, wet, something like that, that's evaporation. Okay. Interesting stuff for 400. You guys are talking behind the scenes, aren't you? Bolus insulin, rapid acting. What is it? Which one's a bolus insulin? Rapid acting. Aspart. Good. Lispro's another name. Miss Witt, anything? Or no? Remembered your names of your insulins. What are the different kinds? What's some of the other ones? What is regular insulin? What's the special thing about regular insulin?
It's the only one you can give IV.
Correct. So the only one that you can give IV.
What about for meal coverage? What's the only meal cover? I mean, the most common meal coverage. Did we already say that? What do you give for meal coverage? Trays will be here in 5 minutes. And what are you going to give? Aspart. That's right. That's right. So it's rapid. What do you know about MPH?
It's cloudy.
It's cloudy. So do you throw it away if it's cloudy? If the patient says, gosh, it's
No.
cloudy. Exactly. And you know your recipe for clear, cloudy, clear, clear, cloudy. You know that. Good.
Are you guys, so regular insulin, whenever you give regular insulin, sometimes you give regular insulin to somebody who's not a diabetic. Who do you give regular insulin to that they're not a diabetic? What's another thing going on with them?
Maybe Cushing's disease. They have high sugar, right?
Yeah, I mean you could, but sometimes we give a dose of insulin. I'm thinking of something specific because insulin works with a specific electrolyte in your body, and it helps get rid of it, helps bring it down. Yeah, potassium. So if somebody is very hyperkalemic, then they give them IV insulin. They give them some regular insulin to help bring it down. And they also, what's another thing they give for their got too much potassium? Anybody remember that from probably last semester? You guys did F&Es last semester. So do you remember what you give for
It's called like
somebody who has really high potassium?
isn't it?
What? I heard somebody talking, but I was talking.
It's K. I can't remember how to say it, but it's like KXLI or something.
K-Exolate, yeah. They give them K-Exolate. And that just makes them have bowel movements, lots and lots of bowel movements to get rid of that potassium. So too high, you said earlier, you said that too high was 5, above 5. What's too low for potassium? Less than 3.5. Good. And if you have too low, what happens? Either too low or too high. What's the thing we need to be watching when we're messing with somebody's potassium? What should we be really paying attention
Cardiac
to?
function.
Yes, because they get dysrhythmias. You have dysrhythmia, stop. So you have to, if their potassium is low and they have dysrhythmia, they're gonna have a dysrhythmia, then they can have a rest. So,
Yes. And
all right, good.
what's the relationship between potassium and sodium?
They're inverse.
That's right. So if you're hyperkalemic, you're probably hyponatremic. How do those people act? They'll have cardiac arrhythmias and
Dementia.
they're confused. Right. That's correct.
That's with the salt that messes with the brain. The water, the fluid shifts in the cells of the brain, so you get the mental stuff, the level of consciousness stuff.
Good.
All right. I saw somebody picked something. Good stuff for 400. Yeah. This results in pulmonary congestion. We already had this one too, right?
That's good heart failure.
Yes, good. All right, next.
Fun stuff for 400. Oh,
Okay. Fetal position most associated with back labor. Remember positions. Sunny side up, but in medical world, that's called occiput posterior. Good. OP. You guys remember that? Whenever you have somebody that's OP, causes that back labor because the back of their baby's head is pushing against mom's tailbone. Very painful, lots of back labor. Sometimes takes longer to deliver. It is a deliverable position. Where would we find, we'll add a letter to this. What if it's LOP? Where would we find the heart tones if it's LOP? Left side, and which would it be, up or down? Lower, higher, or upper? Lower. So since it's O, it's below, and the L would be which side it's on. What if it's RSA? where are you going to find the hard tones? Right, upper. So it's right side because the first letter is R, and it's not an O, so it's not below. So it has to be in the upper right side. Upper. Right, upper side, sorry. All right, we have 4 left. Maybe. There might be repeats. Learn stuff for 300. Most important indicator of fetal well-being on the EFM. This sounds familiar. See, this thing went crazy. Yes, variability, good. I was trying so hard to get this thing to work right. All right, we got 3 left. Learn stuff for 400. This is the opioid agonist antagonist frequently given for IV analgesia. Opioid agonist, antagonist. Remember the drug? There's 2 of them that I can think of. So that's Narcan is what you would give to, not for analgesia. Remember, Narcan is an antidote.
Right.
So this is an opioid agonist antagonist. We would give it to laboring patients all the time.
Is it mag sulfate?
No, not mag sulfate.
Okay, just kidding.
Sydney, just kidding. Sydney said butorphanol. Remember butorphanol? Agonist, antagonist. The other one was now bufene. So these are agonist, antagonist drugs for labor, for analgesia. So those are, we give IV push. We give them during a contraction. Who do we not give these to? Because it is an agonist, antagonist. We do not give it to somebody with a history of, addiction, opioid addiction. You don't give, so something like fentanyl. Fentanyl is a pure opioid. You wouldn't go behind fentanyl and give them some Stadol, because Stadol is an agonist antagonist. It will react with that pure opioid, and it will cause withdrawals. All right, good. Next, 2 more. 300. Prolonged labor, dystocia, LGA, oxytocin augmentation, multiple gestation, high parity, abruption, distended bladder, mag sulfate use, abruptio, etc. These all are what? Risk factors for what? They're all risk factors. They're all associated with one thing. They're all pregnancy related, but what specific? So you have prolonged labor, means it's long time the uterus was working. Dystocia, that's a problem with the labor. An LGA baby would cause it. Oxytocin augmentation, so they added oxytocin to your labor for a long time. Multiple gestation, there's a bunch of babies. High parity, you've had a bunch of babies. An abruption, the uterus has been broken. Has had broken stuff. Distended bladder. Mag sulfate. Uterine atony. Okay, Sam, you're on the right track. What's uterine atony related to what? It's funny you got abruption and abruptio. Uterine atony. Death of the uterus. Bleeding, postpartum hemorrhage. These are all risk. These patients, if they have any one of these, are at high risk for postpartum hemorrhaging. So a big baby, that uterus has been stretched out too big. Oxytocin augmentation, the uterus is getting immune to the oxytocin, so it doesn't want to clamp down like it was supposed to. Multiple gestation, there's lots of babies in there, so the uterus has been stretched out. It takes a long time to get that uterus to get back into that small shape. High parity, you've done it lots of times. That remember 17 and plus, or whatever, that 21 kids or whatever that lady was that had all those kids. Abruption, your uterus it broke, the placenta came off, and then that increases your chance for bleeding afterwards, postpartum hemorrhaging. Distended bladder, won't let that uterus clamp down like it's supposed to. Mag sulfate, what is mag sulfate used for? What kind of drug is mag sulfate? Or mag sulfate? What is it? CNS depressant, okay? And we're using it for what? Yeah, anti-seizure, anticonvulsants. So we're using it to prevent seizures in whom? Somebody with what? Preeclampsia. So you're using the mag sulfate for that, but it also has that nice smooth muscle. Since it decreases your CNS, it also decreases your muscles, your smooth muscle tone. So if it's decreasing your smooth muscle tone, which makes them feel like they weigh 100 pounds extra, they got everything, every time they move, it just takes so much effort. But it also, your uterus is also not contracting like it's supposed to. So after they delivered, they were still on mag sulfate, their uterus might be a little bit boggy because of the mag sulfate. All right. Last question. Tension building phase, acute battery incident, calm loving respite, honeymoon phase. What is that?
Oh, interpersonal violence.
Yeah, and specifically?
It's the cycle of abuse.
Yeah, the cycle of abuse. That's your cycle of violence, your cycle of battering. So that's they have the build up the tension, then the battering incident happens, and then afterwards there's lots of remorse, and then it starts to build up the tension again. Then the battering so it's a cycle, just keeps going around in circles. All right, we have a final Jeopardy question. You ready for your final Jeopardy question? What is 99.99%? Almost 100. Effective birth control. Chris says his HESI score. Chris kind of cheated just a little bit because he's seen this before. This is what you guys are going to get on your HESI. This is your goal. Get 99.99% on your HESI. And it's very doable. It happens every semester to several students. So you can do it. We have faith in you. All right, I'm going to stop sharing this and turn this off for a second. And then I think you get rid of my noise, extra noise here. Hey. We should stop talking over there. Okay. All right, look at all these answers. Okay, we got another thing to talk about. We're going to do like a big review. Anybody have any specific burning questions right at this moment before I pull this next thing up? Nothing. You guys have all gotten signed up for your test, your final exam. Not everybody, but almost everybody's been signed up for their final exam. You got your appointments made. So, and I got an email from each time you did it. And then also when you changed it, I got an email from that as well. So I've been seeing lots of emails come through for that. What else? I'm gonna hide this for a second.
Anna asked if there's math on the HESI, and yes, there's usually math questions on the HESI.
Yeah, there's always
There's
always math. And you know what? I think that our math questions are way harder than the ones they have on the HESI.
Yes. Are we allowed to use the whiteboards on the HESI?
Yes. I put it down with the HESI. I put down specifically that you could use your whiteboard. I put a note in there because you're going to be monitored. So I put a note that they're supposed to be able to let you read your questions out loud if you move your lips without stopping you. So hopefully that's going to be a thing. So that, because I know a lot of you will want to read your questions out loud. And then I think last semester, some people got stopped for reading out loud. There's a note in there that they're not supposed to stop you for that. The calculator is built in to the HESI. It's supposed to be a standard calculator, so you're supposed to have that. I'm trying to think of what else I set that up with the ProctorU. Because so setting up the HESI is one thing, but then we had to set it up with ProctorU. Yeah, I hope so, because I've been saying questions out loud to think about them more. Will they stop us for crying? Kaylee. No, I don't think they'll stop you. But you're not going to be crying. You're going to do great. I cried last semester. Asking for a friend. So yeah, you take your you got lots of focus. It'll all be good. Oh, please, please, please. It might take a minute to get in. So don't panic. Just let it happen. Take your time. You will not be kicked out of the time period. I mean, don't schedule your work to be like 15 minutes after your test is supposed to end. That doesn't, that's not good anytime. You should schedule your maybe your bar visit or something. Of course, you can't do that. It's pandemic. It took me 25 minutes from getting in to getting started. I mean, it did. Last semester, it took a long time, but remember we everybody got thrown into this last minute last semester. So it's not taking as long this semester for people to get into the test, but it does take a little time. So just sit back and relax and wait for them to do their thing and to get yourself in. Make sure you've checked your equipment ahead of time so that you can, you have your video, your webcam working. And you iPad users, I don't think that ProctorU will let you use an iPad. So make sure you've checked that out before you sit there that morning or whenever time you scheduled your appointment for. What else? There's something else I was going to think about. The proctor disappeared halfway through. There's specific we should do in case I kept taking the test. Yeah, just keep taking the test. Just keep moving forward. The proctoring this time is different. I think it's closer to Respondus than, I think the live person doesn't stare at you the whole time, or I don't know. Did you even see? I guess you saw the proctor last time. I think it's like an artificial intelligence thing happening. I know some lady last semester wasn't very nice. I've heard that too. You could hear your person. Could you hear them? Somebody heard them last semester. Somebody heard the person was eating. They could hear them eating. It's like, oh gosh, that's awful. But just try to relax and just try to focus on just the test and, ignore what the person's doing. I do want you, do all the stuff you're supposed to do for a test. Like don't wear the hat and don't say bad words and stuff like that. And he talked me through my panic. Aw, that's nice. I think, like I said, last semester, this was a last minute because everything was shut down and the whole world went to ProctorU at the same time. And so those people were proctoring day and night. There was like people taking tests at 3:00 in the morning. You do have to wear clothes. Yes, we would appreciate if you wore clothes because, yeah, we do view things and we don't want to see naked people, naked test takers. Unfortunately, we have to say that for a reason.
And no vaping, no smoking while you're taking the
Yeah, you shouldn't be. And try to get everybody away from you so you're not talking. Don't have people in your room with you. Don't have grandma sitting behind you over there watching TV or whatever. Get to a room by yourself so you can focus on that. And you have to show your room, and it has to be like a real show your room, not just a quick thing. Don't have your phone like right next to you either. Have that somewhere out of the room or somewhere where you can't get a hold of it. You shouldn't be emailing during your test. You shouldn't be posting things on Facebook during the exam. I mean, that's kind of crazy to think that we have to say things like that, but they make you throw your phone away. What else? There's other things about the proctoring. I really do. I have high hopes that it's going to be better this semester. Last semester, we didn't hear too many bad things, but in fourth semester, they're telling our students from last semester are telling the fourth semester it was terrible. They didn't tell us that. Everybody said it was hard to get in. It took a long time to get in, but
yeah, we
nothing.
hear the specifics like we hear now.
Yeah, and in fourth semester, they're like, yeah, it was terrible last semester. It's like they didn't tell us a thing last semester. We thought everything went over great. So
yeah.
We were misled, apparently.
Yeah. Let us know.
So, anything else about Tessie real quick? Our final exam? I feel like there's something else, and I'll probably think about it while we're talking through this stuff. Your final grades. So, we can't release the final grades until everybody has taken the exam. So the last person taking the exam is like Sunday evening. And I think I told you guys before, I'm shutting down the weighted column as of Wednesday of this week. I had it shut down over the weekend because I was checking somebody's grade and then I forgot to turn it back on, but somebody reminded me. So it's back on. So get that information now. Get all of your tests and quizzes and all those, everything that you need. Get all that stuff in there now. And so you can add up your own score. So you know going in what you need for your HESI, but you should all plan on getting the 99.99%. Don't plan on, I need an 82 to get an 82. Because people do that all the time. It's like, I need an 82, and then they get an 81.2. That does not round up to an 82. So please plan on getting the 99.99%. That's your goal. And it's very doable. People do it all the time. Like I said, I think, don't take my word for it, but I think the math on this, it seems like the math was super easy that they had on this test. Generally our tests are harder than what people say the HESI is, but you got to read the questions. We tried to make it super hard, and then your HESI, you can just come back and blow it away.
That's right.
We didn't try to make it super hard. We made it so that you learned something, hopefully.
You've learned a lot. If you think back over the 16 weeks with OB and now this med surge, you've learned a lot. You've done well.
Can you believe it's over? Not that any of you did, but the withdrawal date is not until December the 17th. This is just a special thing, just like last semester, because of COVID. Don't expect this to happen again in the spring. So if you get done with the exam and you find out that you did not make more than 80% on the whole score for the class, that you were less than successful, you could withdraw, and that withdrawal is not going to count against you this semester. Or it won't count as a failure. So it won't. So if you failed twice before or you failed once before, this isn't your second fail. You'll just sign back up for third semester again in the spring. And it's just like as if it didn't happen. You'll just be well prepared for the spring. So don't freak out or get all upset. I know it's upsetting that if you change your graduation date from spring to fall, but nobody's going to care in a couple of years that when you graduated.
And you won't remember when you get to be my age. You won't know if you graduated in May or December. You're going to be a nurse. That's your goal, and that's what you need to look at.
There's a lot of things you forget whenever you're Mrs. Whitsing.
That's right. Like where your keys are, like your kids' names. Just kidding.
Yes, you are right. Nobody's going to fail. You're just going to, y'all got this. You can do it. If we fail, we get you to another. Yes. You can use that as your goal. You don't want it to be your goal.
I'm sorry, Kaylee, but that's true.
we're sorry that you have to have us for another semester. But you can use it as a positive. So there. I wish we could actually see you guys and really get to know you better. But from the little bits we get to know, I hope to never see you again, is what Chris just said, basically, right?
Right back at you, Chris.
You might not ever see us again, because even back in the old days before pandemic, whenever people would leave in third semester, it was almost as if they graduated the program. We don't see you. Well, Miss Witt will, because she's does fourth semester clinical, but I don't see people again until they pity ceremony. It's like, oh, there you are again, because the whole semester I never saw them. That's not true. No offense. Okay. All right. Well, let's go back, and this is just a little quick PowerPoint. It's just a review thing. We're just going to go through this. So, remember the first unit, Unit 1, had ethics and sexuality. So these are just some things to think about. And I'm going to have this on. I'll post this little thing, just some little reminders kind of thing. It'll be on the course materials, not under, it'll be like Unit 1, 2, 3, 4, 5. It'll be called wrap up or something like that. So this little thing will be on there. There's not really much on here. It's just like little reminders. So remember, as far as ethics and sexuality, think about the code of ethics. So what's some of the ethical principles and stuff that you need to think about that we talk about in nursing? Just a couple, throw out a couple words. Remember some of the ethical principles? They were big words. Remember? Fidelity. It's so funny when you guys all type the same thing. Fidelity, beneficence, non-maleficence, good. So think about what those things are, and you've had ethics before, so we're not going to really go into that. That's why we didn't spend much time on it. But just think there are a lot of ethics involved in nursing. There's ethics involved in every medical decision that's being made, basically. OB has lots of ethical dilemmas. So think about ethical dilemmas. There's rights. Think about client rights. I don't believe there's like a ton of stuff specifically asking like definitions of ethics kind of thing, but ethics are across the board. So there are always going to be like little bits of it in the questions, just like the psych questions are in. There's always like a little bit of a psych question in a lot of the questions. So there's not like 1 + 2 = 3. It's 1 + 2 = the sky is blue and the sun is yellow and all that stuff. STDs. So what are some of the STDs? What do you think about with sexuality? Remember some of the STDs? What are some of the things you can think about? What are some things you might want to remember? That chlamydia. Chlamydia is the number one communicable disease, sexually transmitted disease. Its BFF is gonorrhea. That's right. What if you have lots of STDs? What can that cause? FPID, infertility, because it causes the scarring. Remember the scarring? It can cause ectopic pregnancies because the scarring in the tube. It can cause the sperm can get through. Bad life choices. True. A lot of times they're asymptomatic, so you don't know you have them. But always make sure that if you get treated for them, make sure that what else happens. You need to get treated, but who else? Yeah, make sure that your partner gets treated as well, because you're just going to keep getting reinfected over and over again if one of you doesn't get treated. If there's multiple partners involved, make sure that they all get treated. Herpes is not curable. Herpes is treatable, but not curable. It's your friend for life. So you get herpes, you got it forever. What do you want to know about if they have a herpes outbreak at time of delivery? When they're pregnant and they got herpes outbreak, was something that we need to make sure. Yeah, no vaginal delivery. They need to have a C-section because babies die from getting herpes. If they have an outbreak at the time they're delivering, they have to have a C-section. What else? HIV is also not curable, but very treatable nowadays. Babies don't have to have HIV, even if their mom is HIV positive, as long as mom gets treated during labor and baby gets treated prophylactically with the cocktail afterwards. They can convert to a non-HIV positive. Should a HIV positive mother breastfeed? No. HIV positive or an active TB, active hepatitis, they should not be breastfeeding. If they had an old TB, then they're okay to breastfeed. Contraception. What are some of the contraception things you can think of? Any questions about contraception? Remember, an IUD is when they talk about IUD, they're not talking about the hormone kind. They're talking about just the plain IUD. IUD, birth control pills. Remember, IUD causes the hostile environment to cause so that it doesn't implantation. It stops implantation. It causes the hostile environment. Birth control pills and the hormones do what? Always like whatever they use in the military. Yeah, they prevent ovulation. So hormones prevent ovulation so that you don't have an egg. You're not releasing the egg. Menopause and erectile dysfunction. I just threw those two on there. Those are just two of your exemplar things. So in menopause, how do you know that you're in menopause? because you have periods and stuff, and you're perimenopausal. So perimenopausal, you start off having those hot flashes, and you start having some of the weight gain and that kind of stuff. You're not menopause until after you've been cranky. Listen, Danica, no, I'm just kidding. So you have to go a year without a period to be considered in menopause. The hot flashes and those things can last into menopause. Erectile dysfunction. What are some of the things that you need to think about with erectile dysfunction? Nitro? What would you like to say about that? Don't give. Okay. So you have the medications. If you're taking medications for erectile dysfunction, then you have to worry about that with nitroglycerin, right? Good. All right. Erectile dysfunction is basically you need to remember that males, when we talked about sexuality and we spent a lot of time talking about reproduction,